Hello, good afternoon, everybody. My name is Nina, and I'm joined here today by Tristan, Morgan, Joe, and Travis to explain our research project. And the question is, does blood flow restriction training produce exercise-induced hypoalgesia? And I know what I just said is a huge mouthful, but that is the whole point of today's presentation. Today, we're going to be explaining to you what exercise-induced hypoalgesia is, what blood flow restriction is, and how those two terms are prevalent in the literature. We're going to then explain about the gaps and limitations that are prevalent in the literature and how our research project hopes to bridge some of those gaps. So without further ado, Morgan will start us off.
Thank you, Nina. The benefits of exercise may sound too good to be true, but decades of science confirm that exercise helps improve our health and can even extend our life. Adding as little as a half hour of moderate physical activity a day can prevent musculoskeletal injuries and improve our cardiovascular health and neuromotor control. There's also evidence suggesting that exercise can alleviate symptoms of anxiety, depression, and stressful states. It is clear that exercise improves mental well-being and is a viable preventative or adjunct treatment option for improved mental health outcomes. However, we are here today to talk about how exercise can lessen our body's sensitivity to pain. What causes the feeling of euphoria during a hard workout that we often label as runner's high? That runner's high can be termed exercise-induced hypoalgesia, otherwise known as EIH. EIH has been characterized by elevations in pain thresholds and tolerances, as well as reductions in pain intensity ratings during and following exercise. When we exercise intensely, our nervous system responds to the increase in stress by releasing endorphins. The reason why the runner in this photo on the right is able to smile in the middle of a grueling race is due to the release of these endorphins that act in the substantia gelatinosa of the spinal cord and inhibit painful stimulus. This mechanism is called the endogenous opioid system, and it is our body's natural way of working through pain and restoring homeostasis. Another descending pain inhibition mechanism that explains why we feel less pain when we exercise is called conditioned pain modulation, which is best described as pain inhibits pain. Looking again at the smiling runner on the right, you would not guess that he has been suffering from knee pain because his knee pain is lessened by the uncomfortability of the full body demand required to run a half marathon. After searching the literature, we found that it's not just running that produces exercise-induced hypoalgesia. There is evidence to support that aerobic, anaerobic, isometric, eccentric, and concentric exercise all lessen our body's response to painful stimulus. I'm now going to turn it over to Tristan, where he's going to discuss the barriers of exercise.
So some barriers to exercise include pain-sensitive populations, such as the elderly, chronic and acute pain pathologies. The elderly, for example, may be limited by balance issues and further inhibited by comorbidities such as diabetes, cancer, pulmonary, or cardiac issues. Patients who suffer from chronic pain are unable to adhere to high-load exercises and in most cases, any sort of physical activity. Patients who suffer from acute pathologies are greatly limited by tissue healing, edema, loss of motion, and weakness. In addition, high-intensity exercises, which are required for progression in function and strength, will be difficult to attain for this population. The literature also notes that muscle weakness or atrophy due to common musculoskeletal conditions such as osteoarthritis or total arthroplasties can limit one's ability to exercise. Lastly, we have other barriers to exercise, which include the fear of injury or re-injury. For example, if an elderly patient were to fall during exercise, he or she may become traumatized by that event and avoid further exercise. Now, Travis will actually help us discuss how blood flow restriction can be a possible solution to assisting overcoming these barriers.
But first, what is blood flow restriction exactly? Blood flow restriction, or BFR, is a training technique where a pressure cuff is applied to a proximal limb segment and inflated to partially occlude arterial flow to to the distal segments of that limb. Depending on the limb and the study, as low as 30% or as high as 80% of the blood flow may be blocked. You then exercise the occluded limb. Research has shown that exercising with BFR using low loads leads to similar strength gains and muscle hypertrophy as traditional strength training with high loads. This alone makes BFR a possible solution to some of the barriers experienced by the many patients who cannot bear high loads or have baseline pain that prevents them from exercising at the intensity required to progress their rehab. Back to you, Nina.
Thank you. Now, what Travis just went over is the crux of us combing through the literature and finding how BFR can produce an EIH effect. And these bullet points that we've listed right here go through the main ideas of what we were able to find. So now we're going to go into each bullet point in depth and explain to you what we found. Joe?
Thank you, Nina. All right, now let's take a look at some common ways to measure pain. We have our subjective measures and our objective measures. For the most part, studies have been measuring pain perception subjectively. This is typically done with a tool like the visual analog scale or numerical pain rating scale, where the participant does their best to estimate the intensity of their pain in terms of where it falls between their perceived minimum or maximum. Subjective pain ratings can also be taken in the form of a questionnaire where the participant reports how pain is experienced in a specific region of the body throughout the day. These subjective measurements are cost-effective and easy to use in clinical or research setting. Less commonly, pain is measured objectively. This is usually done with a special tool that gradually applies the stimulus. One such test is the pressure pain threshold. Pressure pain threshold is defined as the exact point where the feeling of pressure applied to the skin first starts to feel painful. This can be measured with a device called an algometer, which has a rubber tip on the end. The tip is placed against the skin, and pressure is gradually applied until the person reports pain. The amount of pressure it took to reach that point can then be read off the device. Similar devices and strategies can be used to measure cold pain thresholds and heat pain thresholds. Now we're going to hear from Travis. Take it away, Trav.
So what does the research say about BFR and EIH? Well, to date, there are only 7 studies on this. 5 of the 7 studies explored the connection between BFR and EIH by examining pain levels or pain sensitivity of the exercising limb while the BFR cuff occluded blood flow to that limb. Although all 5 of these tested open kinetic chain knee extension and leg presses, and thus more or less only tested the quads, their exercise protocols were extremely consistent with one another, increasing external validity. All 5 studies found that EIH occurred while exercising, and the reduced pain level or reduction in pain sensitivity lasted for up to 24 hours after exercise stopped.
Okay, now we're going to go one step further on what Travis just said. Jones et al. In 2017, as well as Hughes and Patterson in 2020, found research to indicate that BFR leads to EIH even in the unexercised limb, which is really amazing because if we think about the clinical applications of their findings, you realize that if a patient comes into you with unilateral pain and they feel kinesiophobia about it, they don't want to move it, and the patient may not want you to move their limb, you could theoretically start introducing therapeutic exercise to the contralateral side, have them exercise that, and that exercise on the contralateral limb would lead to exercise-induced hypoalgesia on that unexercised limb, which is an amazing way to think about the indirect method for treating a patient's pain.
We also found evidence to support that BFR creates an EIH response during resistance training. In a patient population suffering from anterior knee pain, lower extremity knee extensions were performed with and without BFR. Subjective pain ratings were taken immediately after the cuff was applied and 45 minutes after the physical therapy session. The group using the BFR cuff found longer hypoalgesic effects than their resistance training alone. This study suggests that BFR could be used clinically at the beginning of an appointment to allow patients to get through a physical therapy session with less discomfort.
Just this month, Hughes and Patterson released a pivotal study comparing low load resistance exercise, high load resistance exercise, both of those without BFR, BFR at low occlusion percent, and BFR at a high occlusion percent. They also took blood samples before and after exercise to analyze beta endorphin levels, since beta endorphins are the products of the endogenous opioid system that Morgan told us about earlier. Overall, they found that high occlusion BFR causes a greater EIH response in the exercising limb when compared to the other conditions. This EIH response lasted for up to 24 hours post-exercise only in the exercising limb, and for less than that in the non-exercise limbs. They only tested the 5 minutes. The reduction in pain sensitivity was partly driven by endogenous opioid production of those beta endorphins, which their statistical analysis said that this accounted for about 40% of the EIH response. And reduction in pain sensitivity was also partly driven by muscle discomfort, accounting for the other 60% reduction in pain. However, we did find one study stating that BFR did not lead to EIH, which Tristan will tell you about now.
So in this study done by Maddox in 2017, it did observe an increase in discomfort post-BFR training, which consisted of 26 young and healthy adults who performed unilateral elbow flexion with BFR occlusive pressures ranging from 0, 10, 20, 30, 50, and 90% of resting arterial pressure. The findings of this study revealed that ratings of discomfort increased as occlusive pressures increase. However, we did notice many flaws in this article, which could have resulted in the increase in discomfort. As mentioned above, these patients were all healthy, and it is possible for a subject who had no pain during the baseline recording to have intense discomfort at their elbow post-BFR. In addition, the blood flow restriction would occlude arterial pressures as high as 90%, which may explain the increase in discomfort. The occlusive pressures were also randomized, but the subjects had a high probability of beginning their exercises at lower restriction pressures. For instance, the subjects that may have begun with a low pressure would experience less discomfort and set this rating as their anchor for their next restriction pressures. When the pressure increased or the max restriction pressure was obtained, this would cause an increase in discomfort due to the exposure of low levels of BFR in the previous sets. It is also worth noting that the study did not blind their subjects with the occlusion pressure that was applied, which could cause these patients to note that higher occlusive pressures would be more painful or uncomfortable. Lastly, only one testing session was administered, whereas some of the previous studies shown positive correlation with EIH observed with more than one testing session.
All right, so we've heard a lot about BFR training and its relationship to exercise-induced hypoalgesia. But when is this tool helpful to us? Blood flow restriction training has been shown to produce both immediate and long-lasting hypoalgesic effects. Not only does the user experience higher pain tolerance while the activity is being performed, but this effect can last for some time after they've stopped. One study using BFR in participants with anterior knee pain showed that a single session was enough to lower pain ratings for up to 45 minutes. So not only does the patient get the pain reduction benefit of lifting lighter loads, they also get a hypoalgesic effect that can last throughout the rest of their PT session. Another study on patellofemoral pain showed that low-load BFR training leads to pain reduction with activities of daily living that can last for several weeks. However, it can't be determined if this is an actual hypoalgesic effect or if the reduced loads through the knee led to better pain outcomes in the standard group. Through our research, we've started to notice some patterns and some questions that have been left unanswered. One thing that we've noticed is that pain is usually considered as a secondary outcome, with hypertrophy being the main focus of the study. One problem with this setup is that pain ratings are commonly taken during the BFR exercise itself. And if you've ever done BFR training, you know that it can be pretty painful. This can interfere with the researcher's ability to detect a hypoalgesic effect. Another issue is that pain ratings are usually taken subjectively. While subjective pain measurements are typically more affordable, they're not as reliable as an objective measurement like pressure pain thresholds. With a range of subjective pain measurements being used by these studies, the results can be difficult to compare to one another. Also, most studies have focused on a specific patient population, such as young people with knee pain. This can make it difficult to generalize the findings to the rest of the population.
So we also wanted to mention the study we are participating in, which consists of healthy individuals who are performing 3 different exercises with blood flow restriction throughout 5 randomized testing sessions. We are using this device called an algometer to objectively obtain a pressure pain threshold in order to determine if blood flow restriction causes exercise-induced hypoalgesic effects. This picture here shown on the slide is what we give to our subjects in order to better help them or assist them in identifying this pressure pain threshold, where that small blue region on the bottom is perfectly defined as that pressure pain threshold. And lastly, given what we have learned in the literature and a recent study done by Hughes and Patterson in 2020, we hypothesized that blood flow restriction training will lead to a better exercise-induced hypoalgesic response than resistance training alone. The next 2 slides just show our references. I hope y'all enjoyed the presentation and have a great rest of your day. Woo!